It's still no, it's an adaptive platform trial. So it's still there's different. It's just a platform of individual randomized controlled trials, which can have more than two arms. They can theoretically have as many arms as you like. And every trial going on within the platform has the same primary outcome, which is an ordinal outcome of the bad things that happen to preterm babies, assessed at term, essentially. So anything that goes into the platform has to fit with that primary outcome in the sense that it has to be adequate for what you want to know. So if you want to do a speckle tracking trial and your primary outcome's physiological or echocardiographic, it doesn't fit well with platypus. Platypus is good for big questions, improving outcomes, and there's two parts to it. There's the platform that we hope will involve all the centres around Australia and New Zealand and maybe beyond. And then there's the adaptive part, which is the ability to drop or add arms once they're proven to be superior or inferior.
Wait, I'm getting a text from Arvin saying that he can't open the link, but I do see people on here. It's not always the same link. Damn. How do we do that? New email, Arvin's. He's eager. So sorry, I'll just
yeah, you sort that out. Yeah. Worked okay for me.
And that was just the normal invite, wasn't it?
Yeah, I just used the webinar invite. Yep.
Yeah. Okay. All right. Also,
I think, Kurt, sometimes if the login number and the password is not there separately from the link, it doesn't link. Usually, they put the number, ID number, and password separately. Then they can open up Zoom and key in the number. This time, only the link has been sent. Thank you.
Okay. So, okay. So I got a link. Yeah, I see. With a number, passcode, you mean?
Yeah.
Show. I'll just email that again.
Email and WhatsApp as well.
Yep. But the WhatsApp was good, I guess. That had the stuff into it. Pretty sure.
It worked okay for me.
There you go.
It worked for us, no problem. Just one click, you are in.
On the top in the WhatsApp has got the link on it, because you don't need a passcode to get in, to be honest. Let me see.
Yeah. But sometimes not possible from outside.
We still got a couple of minutes, so I think he should be fine. Ivan should be fine.
Yeah, he's here now.
And other people, he's here now. So okay, so it is working. Cool.
Hello, Brett. Good morning.
Hello, Prof. Sam.
Afternoon for you. Afternoon, yeah.
Lovely to see you as always.
Yeah.
Have you recovered from your misadventures?
Yes. Now post-COVID syndrome, so still on leave. Bit of sleep disturbance and other things. I will overcome and bounce back.
Oh dear. You must be getting sick of hearing these results, Prof, but always love to have you there for the discussion.
No, I always learn new things. Just call me Sam. Brett, you always forget.
Okay, Prof. Sam, I will.
Because at the end, you bring challenging thoughts, even in Christchurch, even though I was hearing for the third time.
Yep, good.
All right. 1 second. Great. That one's also out. And there's still people coming in. I think, Brad, we're going to start soon. What do you think?
Yeah, happy when you're ready, Kurt.
Yeah. Uh-oh. All right. Thanks everybody for joining. If there was a misunderstanding with the link, well, only the people with the link are here. So I will apologize later for the others. I'm not sure if anything went wrong or not, but it is not the same link every meeting, that is for sure. So I'll make that clearer in my invites later. Today, it's my great pleasure to introduce Professor Brad Manley. Just recently promoted, I hear, well-deserved, a neonatologist at the Royal Women's Hospital in Melbourne, Australia, and a trialist by heart. I remember walking somewhere in Kuala Lumpur, I think it was, with Brad, and he said, I just want to do trials. I just want to do trials. And his motivation has led to be honest, numerous large, important question trials in our field where we all benefit from. So today he's going to talk of his most latest trial, the PLUS trials, and over to you, Brett.
Thanks, Kurt. That was a great impression of me, actually. It was uncanny. It's a real pleasure to be here, as always, to present the results of the PLUS trial. I'm aware for some of you this won't be the first time you've heard them, but I hope you still find them interesting. And for the rest of you, I hope this is exciting to hear the results after many years of the PLUS trial. So I'm not going to tell you about BPD, which remains a big problem for us in neonatal units looking after smaller and smaller babies, where this diagnosis is more and more common. We could argue, of course, for a long time over the definition of BPD that's the most relevant, but whichever way you look at it, we know that the sicker babies with worse lung disease tend to have more trouble both in hospital and once they've gone home. And there are several ways that this could be illustrated, but just coincidentally, Jeannie Chong sent me this paper about 15 minutes ago, which they've just published from the Victorian Infant Collaborative Study Group with Lex Doyle as first author. And what they've done is they've looked at the relationship between different diagnoses and severity of BPD with lung function and neurodevelopmental outcomes at 8 years of age. So this is hot off the press and very exciting. And basically what it tells us is that those with very mild BPD tend to have no worse respiratory function at 8 years, but anything more than mild, they do. And similarly, anything more than mild is associated with adverse neurodevelopmental outcomes as well as adverse respiratory outcomes later in life. So the things that are happening now are important to how our babies, the baby's health later in life. And when we were designing the PLUS trial back in 2017, this was what we thought was going on, that extremely preterm babies born before 28 weeks gestation had about a 50-50 chance of surviving without BPD or of dying or having BPD. However, if we look at some more recent data, I think we've underestimated that quite significantly, and I'm sure those of you working in neonatal intensive care units would be familiar with this phenomenon. Here's American data from the Vermont-Oxford network, and if I zoom in on the babies born before 28 weeks, in red is a diagnosis of any grade of BPD and or death. And what you can see is that the rate of BPD or death is extremely high in those really periviable gestations, and in fact doesn't drop below 50% until 27 weeks of gestation. And more closer to home in the Australian-New Zealand Neonatal Network, these are the latest data up to 2021 for the decade previous. And rather than us improving our rates of BPD, what we're seeing is subtle increases in the rate of BPD in the tiniest babies, and even a significant increase in the diagnosis of BPD in the more mature, extremely preterm babies. And we understand that BPD is so difficult to treat because it's multifactorial. The inflammation and the problems with development of the lungs that lead to BPD are starting even before birth and certainly in the delivery room and in the early parts of the NICU stay. And of course, at the centre of all of that is inflammation from a multitude of causes. And that's why strong anti-inflammatory drugs like postnatal corticosteroids have been a mainstay of trying to treat or prevent BPD for their anti-inflammatory action. Well, here's Lex Doyle again, and again, some of us will be familiar with his meta-regression papers. This is the one from 2014, although I just came back from Toronto from Pediatric Academic Societies and saw that he's in fact updated this recently, so I'm sure that will be published soon. But long story short, what we've got here on the x-axis is looking at all different studies, the risk of BPD in the baseline, in the control group of those studies, compared with the rate of death or BPD in those babies. Sorry, the effect of death or cerebral palsy at 2 years in those babies. And to cut a long story short, as the risk of BPD increases, the risk of death or cerebral palsy from using postnatal corticosteroids decreases. It's all a bit of a jumble, but what that means is, and this is how most of us practice now, that we try to reserve the use of systemic postnatal steroids for those babies at high risk of BPD. Of course, we could again have a discussion about what does this mean in today's age. If a 22-weeker or a 23-weeker is admitted to your unit, surely they already have a more than 50% chance of BPD, which they do. But there's still this problem we have, because even though we're careful about how we use postnatal steroids, we try and delay the use of these until a week or two of age, in line with the Cochrane reviews and other evidence telling us that that's the safe way to use them. We still have this therapeutic gap straight after birth and in the first week or two of life where inflammation is evolving. And if we could find a safe way of giving early postnatal steroids to these babies, that might be beneficial for them. So various things have been looked at. You may be familiar with the Prevenir trial of prophylactic hydrocortisone given from birth for the first 10 days of life. And this is a trial that's created much discussion because, in fact, that practice did seem to result in a small reduction in the primary outcome of death or BPD. However, the use of hydrocortisone is associated with adverse effects in this scenario as well. And when different trials have been pulled together, the effect seems to be relatively small and requiring replication in larger trials. So it's something that some people are doing, and in fact, something that we might all be doing in the future, but certainly in my opinion, we're not quite there yet. Well, what about giving steroids into the lungs? So the other trial that I mentioned here is the Neurosis trial, another randomized trial from Europe where babies, extremely preterm babies, were given prophylactic and prolonged inhaled budesonide, a type of corticosteroid that's useful to be given directly into the lungs. And this was using a metered dose inhaler like we use for our asthma treatment, or being given into the respiratory circuit. And these babies were given very prolonged courses of inhaled budesonide, sometimes for months. And the outcome of that trial was that, again, there seemed to be a borderline reduction in the primary outcome of death or BPD, but the trade-off, when it was looked carefully, was in fact that the rate of mortality increased in those babies who received budesonide, both at discharge and into the longer term. So this has been thrown out for the moment as a therapy that we should be using because of that safety issue. So here's budesonide and what it looks like, at least in the Australian setting. This is a respule of Pulmicort, Pulmicort being a drug that's used regularly for asthma, and for any of you affected by COVID, poor Sam from Singapore is still recovering. You might have in fact been treated with budesonide as a respiratory therapy. It's a good drug for pulmonary administration because it's got a very high affinity for local glucocorticoid receptors in the lung, and in fact is 5 times more potent in its anti-inflammatory action than dexamethasone. And also, at least in preclinical settings, the systemic effects of its metabolites seem to be minimal. So even if it's absorbed into the bloodstream through the lung, it may be a safe drug. And another advantage is that in my hands here in Melbourne, Australia, this costs about $1 per respule. I showed you the Neurosis trial where infants receive budesonide via inhaled technique, but perhaps it might be better to give it directly into the lungs, bypassing the upper airway, the problem that we always have with inhalation, especially in small babies, and giving it down an endotracheal tube or down some other tube directly into the trachea and down into the lungs. So if we could do that, that would overcome those issues that we've seen with inhalation, obviously would be effectively delivered to the airways using a vehicle such as surfactant that we're giving to nearly all of our extremely preterm babies and that we know is well distributed through the lung. And as long as it didn't have any effect itself on the properties of surfactant, then this would be a really safe way of giving it, we would think. This is a photo of Aaron Sett, who works at the at Sunshine Hospital, Joan Kerner Hospital here in Melbourne. He's a neonatologist that recently published this review looking at surfactant as a drug carrier for various indications in preterm babies, but a lot of the evidence was in fact around this very indication of giving steroid or budesonide directly into the lungs. And here's a summary of 6 preclinical studies, not to go into all the details, but you can see that that combination of surfactant and budesonide in all these studies written here in the green text improved lung function, inflammation, and oxygenation compared to surfactant alone in animal models. And this is not a new idea. This is Professor Su Ye from Taiwan, who's been at the forefront of investigating this combination of budesonide and surfactant for preterm babies. Here's some earlier work from his group, again in a preclinical model. This is a rat model, showing that when you inject radioactive budesonide into the trachea down an endotracheal tube, what happens here is that you can see some in the left-hand panel, some very bright budesonide there in the large airway, but after only 30 to 45 minutes, that dissipates and really is gone from the lungs and the large airways very quickly. But if you combine the budesonide with surfactant, you can see quite easily from these slides that the budesonide is better distributed through the lungs into the small airways, not just at the large airways, and it seems to hang around in the lung for a lot longer than when it's administered on its own. So using surfactant as a vehicle for the budesonide seems to be a good thing to do. And he's taken that concept further and currently has led 3 randomized trials of this combination of a dose of 0.25 milligrams per kilo of budesonide and surfactant. And that dose of budesonide is the same as been used in the preclinical trials and been shown to be effective. So he's got these 3 randomized trials. I'm not sure if anyone on the line's been involved with these. The first 2 have been published, the 2 Savanta trials, and the 3rd trial used CuraSurf and was recently finished and we're waiting for that to be published. But these results have been presented in several forums, so they're not confidential in that sense. And I want to point out the types of babies that were enrolled to these trials. These were very low birth weight infants, but they were relatively mature extremely preterm babies with a mean gestational age of around 27 weeks and a mean birth weight of around 1 kilo. But they were also quite sick, so most babies enrolled in these trials were on a mechanical ventilator and most had quite a significant oxygen requirement in the first hours of life. And for those of you familiar with these studies, you'll already know these results. There's a fairly dramatic reduction across all 3 of these trials in the primary outcome of death or BPD. So dramatic, in fact, that I don't think we've seen a reduction like this for any other therapy demonstrated in any recent trial. So this has clearly raised everybody's interest. And in fact, some people around the world in quite a few centres have been giving this combination of budesonide and surfactant in routine clinical care since the results of these trials. If we look a bit more closely at the components of the primary composite outcome, we can see that nearly all of this efficacious effect is on BPD rather than death itself, so almost a halving of BPD. And there's been some other smaller randomized trials, and they have very small sample sizes ranging from only 30 up to the size of the Yay trials. But when these results are pooled in a meta-analysis, you can see that this result holds basically a halving of the rate of BPD when all of these data are pooled. So why did we go on and do the PLUS trial? Well, firstly, all of those data weren't available at the time we designed this. But it's important to note the small to moderate size of the existing randomized trials, ranging from only 30 up to now, the most recent Yay trial, 310. Nearly all of these trials come from one region of the world, China and Taiwan, and haven't really been tested in other populations. They didn't include many tiny babies, and I'm really talking about those babies born before 25 weeks gestation that many of us are struggling with, knowing what the best therapies are for those babies in our NICUs as we look after more and more babies born at 22 and 23 weeks gestation. And the results of those trials, particularly the A trials, might not be generalizable to some of our newer practices. I mentioned all of the babies were on mechanical ventilation, often in a lot of oxygen, whereas we're moving much more towards non-invasive modes of respiratory support and less or minimally invasive surfactant. And in fact, in a unit like mine, it's rare for babies of that sort of gestational age, 27, 28 weeks, to be mechanically ventilated from birth. In one or two of the trials, there was some potential for bias in the investigators being aware of some of the group allocation. And lastly, despite that dramatic effect on BPD seen in some of the trials, there's no evidence of longer-term benefit to health in the one study that has reported outcomes to 18 months, and we wait to see what the most recent YEA trial shows. So we got together back in 2017 and designed the PLUS trial, preventing lung disease using surfactant and steroid. And bear with me as I thank a whole lot of people. I think it's really important in a forum like this to acknowledge just how many clever people it takes to run a trial like this. Here are the trial steering committee and other key members of the PLUS trial management, including the data safety and monitoring group, statisticians, and trial coordinators. And of course, the trial went all around Australia and New Zealand and to Singapore and Edmonton in Canada. And I asked everyone to send in some photos of themselves just to really acknowledge the amount of work that goes into this, not just from the named site investigators, but from all the other people that do the enrollment and recruitment and data collection and everything else that goes along with this. This is pretty much a full-time job for the duration of the trial, and we thank everyone. And of course, we have to thank the incredible families who are always willing to not only enroll their children in the first hours of life sometimes, or even the first minutes of life sometimes, but to help out with trial promotion and all that sort of thing along the way. So the PLUS trial was sponsored by the Murdoch Children's Research Institute in Melbourne, and its main funding came from the Australian government from a clinical trials and cohort studies grant. But Chiesi Pharmaceutici that makes Curasurf did reimburse the cost of surfactant to participating centres that was used within the trial, which was very helpful. And we're now undertaking 2-year outcome assessments that are funded by Thrasher and Cure Kids. So what did we do? The population in the PLUS trial were extremely preterm infants born before 28 weeks gestation, with no lower limit for gestation. The intervention was intratracheal budesonide, 0.25 milligrams per kilo. So that's the same dose used in the previous randomized trials and preclinical trials, mixed with surfactant. And the surfactant we used was Practin alpha or Curasurf at a dose of 200 milligrams per kilo for the first trial intervention and 100 milligrams per kilo for a second trial intervention if it was given. And I'll explain how that worked in a minute. And the comparator group received surfactant alone at the same doses. And the primary outcome was survival-free of physiological BPD at 36 weeks post-menstrual age. So babies had to be extremely preterm. They had to be less than 48 hours old to enter the trial, and they'd had to have no more than 1 prior dose of surfactant. And again, I'll describe how those babies got into the trial and why shortly and in the discussion. And to be eligible for the trial, extremely preterm babies needed to be either mechanically ventilated, regardless of any ventilation settings or oxygen requirements. So simply having an endotracheal tube in situ was enough to get into the trial, even if babies were in air or regardless of what their ventilation settings were. Or the other way was a baby on non-invasive respiratory support, such as CPAP, and there was a clinical decision to treat with surfactant in any way, including either via inserting an endotracheal tube or via a less or minimally invasive surfactant technique. Exclusion criteria were few. Only babies who'd already received postnatal corticosteroids for lung disease were excluded, or if they were in such extremis that they were unlikely to survive the first hours in the NICU. If there was a known or suspected major congenital anomaly, such as major congenital heart disease or gastrointestinal anomaly, however, severe pulmonary hyperplasia babies were usually included. Only excluded were those babies with severe pulmonary hyperplasia already born, where the attending neonatologist thought that they were not going to survive. And the only other exclusion criteria was if babies were planned to be transferred to another unit. So this is the flow chart of how infants might enter the trial. So those that had had no previous surfactant, i.e. they'd come up to the NICU either intubated but hadn't had surfactant yet, or they were on non-invasive respiratory support, were all eligible for the trial via the two criteria I mentioned earlier. Either they were intubated or on non-invasive support, and there was a decision to treat with surfactant. But we also made the decision to design the PLUS trial such that babies who had already received surfactant prior to being consented and enrolled in PLUS were still eligible. So these babies were assessed in a window 6 to 12 hours after their first dose of surfactant. These are babies that normally would have been given that might have received surfactant in a delivery room or soon after arrival in NICU before there was any time to consent and enroll. And similarly, if 6 to 12 hours later they were on a mechanical ventilator or there was a decision to treat again with surfactant, they could be enrolled. And this was a decision to try and get as many extremely preterm babies into the trial as possible and to make sure we didn't introduce any selection bias by, for example, systematically excluding the sickest babies who needed early surfactant. However, babies were eligible, they were then consented, always with prospective consent, randomised and received their first intervention. And then they were assessed 6 to 12 hours later again with the same criteria. And if they remained on a ventilator or there was a decision to give another dose of surfactant, then the second intervention was given. And then that was the end of the trial protocol. So for most babies, this was all done and dusted in the first 24 hours of life, sometimes sooner. This is what it looked like to prepare the intervention. There's a syringe of Curasurf on the left and a syringe of Budesonide, the volume being only 0.5 ml per kilo in a 1 ml syringe there. And you can see the Pulmicort Respule and the Curasurf vial. And then just ignoring that this person hasn't got gloves on, this was a setup in the teaching room. This was not being given to a baby, but we should have had gloves on. You can see that the two therapies were mixed together, either just directly by squirting one into the other and then inverting the solution several times, or via a connector, whatever centres wanted to do. And this was all done away from the bedside of the enrolled infant by an intervention team of 2 clinical staff that were not involved in the direct care of the baby. So in my hospital, that was often by 2 nursing staff from a different part of the unit who weren't looking after the enrolled patient. And by this technique, we were able to keep all the clinicians looking after the baby, the trial investigators, the families, and the outcome assessors blinded, to the intervention. And then this was taken to the bedside and administered by whoever would normally administer surfactant. And as I already mentioned, that could be either down the endotracheal tube or via a LISA or mist technique. The primary outcome of the PLUS trial was survival without physiological BPD at 36 weeks, and this was our definition. It was assessed in the 36th week of postmenstrual age. And BPD was diagnosed if babies were on respiratory support at the time, including high flow of 2 litres per minute or more, or if they were receiving low flow or ambient oxygen with an effective fraction of inspired oxygen of at least 0.30, or if they were receiving less oxygen than that, but they had an unsuccessful air reduction trial. So the babies who needed very little oxygen and in fact were able to manage without oxygen for a short period of time were not diagnosed with BPD. The sample size that we estimated on a primary outcome rate of 50% back in 2017, we need for 90% power to increase survival free of BPD from what we thought was 50% up to 60%. We needed 1,038 extremely preterm infants, and we inflated this slightly and aimed for 1,060. Randomisation was an online REDCap system, and babies were individually randomised. As with all trials in very preterm infants, we have a lot of multiple births. Each one was randomised separately using randomly permuted block sizes. And we had 3 randomisation strata: gestational age, babies less than 26 versus more. I think if I was designing this trial again, I probably would have gone for less than 25 versus more, but things change over a decade. The mode of respiratory support that they were receiving, which was either mechanical ventilation or non-invasive support, and as we've mentioned, whether they'd had prior surfactant or not. And if you want to do a lot of in-depth reading about the ins and outs of a big trial like this, we've published our trial protocol and our statistical analysis plan in the journal Trials. So feel free to go and have a read of those. So to the results of the PLUS trial. So this was a big effort from a lot of people involving 21 NICU, tertiary NICUs in 4 countries, being Australia, New Zealand, Singapore, and Canada. And thank you to all of those on the line that were involved in the trial. It was really great to bring most of the NICUs in Australia and New Zealand, particularly, together on one trial. And these things take time. A major issue in perinatal clinical trials, as you'd all recognised, here's Omar, Brenda, Jennifer, and myself with the first baby being randomised back in January 2018, and recruitment was completed for the trial about 5 years later in March 2023. Here's the first baby receiving their surfactant at the Royal Women's Hospital, and here's the last baby being randomised in March last year. So we screened over 2,800 extremely preterm babies who'd been admitted to a participating NICU, of whom about 2,300 were eligible. The most common reason these extremely preterm babies were not eligible for PLUS was a good reason, being, well, probably a good reason, which was that they were maintained on non-invasive respiratory support and did not need surfactant. So it's important to point out that we did not recruit all of those fairly well 27 and 26 weekers that you might have seen in other trials in extremely preterm babies. About 1,200 were not able to be consented or enrolled. You can see of those, about a third were declined by families. Overall, our consent rate was pretty good. And then there was a variety of other reasons why babies were not enrolled. That left us with 1,062 babies randomised, which is achieving our target. That's about just under half of all eligible extremely preterm babies. 525 into the surfactant plus budesonide group and 537 into surfactant only. And then there was a couple of babies who had consent withdrawn for participation in the trial in both arms, leaving us with an intention to treat population of 1,059 babies. This is the demographics of the mothers of infants enrolled in the trial. You can see just about 2/3 of mothers were European or Caucasian, i.e. white. About 20% were Asian. And then we managed to enroll a nice smattering of Indigenous populations from Australia, New Zealand, and Canada into the trial as well. We're really good at giving mothers who are going to have an extremely preterm baby some steroid, but this might have been only for an hour or 15 minutes prior to the birth. But you can see almost all mothers were exposed to some antenatal steroid, but that drops down to only about 2/3 of mothers who'd had 2 or more doses of antenatal corticosteroid. About 40% of all mothers or all placentas showed signs of histological chorioamnionitis at histology, and about 1/3 of mothers had prolonged rupture of membranes. 2/3 laboured before the birth and 2/3 were born by caesarean section, and they're proportions that we see in other trials as well. Here's the demographics of the infants, and we're quite proud of this as a collaboration that we were able to enroll very small babies. So compared to the previous RCTs, you can see the mean gestation at birth is around 25.5 weeks and the mean birth weight around 750 to 800 grams. 14% of babies were small for gestational age, just over half were male, about 1/3 were multiple births. I mentioned earlier, there's always a lot of multiple births in these trials, and about 2/3 were intubated in the delivery room, again, indicative of the illness of the babies. And here's a simple bar chart looking at the gestational age of babies enrolled in the trial. And I bring your attention to the really tiny babies that we've been struggling to enroll into clinical trials in neonatology. You know, many of our landmark clinical trials, in fact, excluded this population of babies or didn't enroll many. You can see we had 350 babies here born less than 25 weeks. And if we look at birth weights, we had over 200 babies under 600 grams enrolled into the trial. Here's some more demographics of the babies showing that just over half had received previous surfactant. So almost half hadn't and had. The average or median fraction of inspired oxygen was around 0.30 in both groups at randomization, and the age at randomization was around 4 or 5 hours. If you break that down by the babies who'd previously received surfactant, then by our trial protocol, they were enrolled later, 6 to 12 hours after the first dose. If you just look at the babies who had not had prior surfactant, they were enrolled earlier in the first hour or two of life on average. Here's what actually happened. Clearly, there's always some strange things that happen in clinical trials, but less than 1% of both groups didn't receive any intervention. About 1/3 had one intervention and 2/3 had two interventions. This is how the medications were given to the babies. For the first intervention, about 14–15% of babies received it via LISA or MIST technique, which is terrific to have that population enrolled, and about 80% via 80 to 90% via endotracheal tube or INSURE. And then you can see for the second intervention, this understandably changed, because those babies were more often deemed to require a second dose of surfactant and so were more often intubated, and there was a lower rate of LISA or MIST for the second intervention. So to the primary outcome, which again, I remind you, is survival without BPD at 36 weeks post-menstrual age. We estimated that this might be 50% in the control group. Well, here's the intervention group, the rate of around 26% here, and in the control group, 23%. So this is not a big difference between the groups in the primary outcome, a slight increase in the intervention group compared to the control group. There's a risk difference of only 2.7% and a confidence interval that crosses 0, the point of no difference. So if you enter statistical significance, this is a non-significant result. If your brain works the opposite way because you're used to all of our trials reporting death or BPD, here are those results, which is just the converse of the previous slide. So 74.5% versus 77.4%, a small but not significant difference with budesonide and surfactant. Always important to look at the components or the things that make up the primary outcome. And here are they. So babies alive at 36 weeks post-menstrual age, again, a small increase in the intervention arm. The rate of BPD, a small decrease in the intervention arm. Being alive at hospital discharge, again, a small difference, not significant. And if we look at the severity of BPD, and here I've used the most recent Jensen criteria from 2019, you can see by just scanning down the different severities, there's really nothing going on between the groups here. They're very, very similar. I just added this slide yesterday. I think something that we've also been not great at doing in our trials of extremely preterm babies is looking at the babies that died and how they died and why they died. So we'll be able to look at this in the PLUS trial. We classified every death, independently by the DSMB as to whether they thought it was respiratory or not. And you can see that there's an identical proportion of babies classed as a respiratory death who died within the PLUS trial. It's interesting to see how and why babies die, and perhaps not unexpectedly, the most common reasons are for redirection of care, presumably because of some adverse event that is deemed to be a very high risk, or for life support being withdrawn in a baby who's dying. But it's very rare for babies to die actively receiving CPR, for example. And the most common causes of death are the ones we also know about, being IVH or complications of IVH or infection. We pre-specified looking at the primary outcome for some things that we knew might influence it from previous trials. So firstly, we started with the gestational age and pre-randomization strata. What I'm showing you here, just to go back a bit, is that the grey vertical line at 0% is the point of no difference between the groups. Anything to the right favours budesonide, anything to the left doesn't. So without me going through them individually, you can see that all of these point estimates and 95% confidence intervals cross the point at 0, meaning that they're not significant. And I'd also point out that the within group differences, i.e. the interactions within the groups, are also not significant. So there's actually no important effects going on here, either by gestation, by surfactant therapy, by type of support, by infant sex, by small for gestational age, even though the risk difference is 1 on the other side. by chorioamnionitis, which I guess is a little surprising given some previous results showing that infants exposed to chorioamnionitis were more likely to benefit. And there's the full data highlighted in yellow at the bottom. We looked at a whole lot of secondary outcomes, again, being mindful particularly that a diagnosis of BPD at 36 weeks may not be what we move forward with as a specialty and may not be important to families. So here's respiratory support or oxygen at 40 weeks gestation and postmenstrual age, I'm sorry. And again, small difference, but not significant. The rate of the need for systemic postnatal corticosteroids later in the stay was absolutely identical. 1/3 of babies received postnatal corticosteroids for lung disease. Discharge home on oxygen, also identical. The duration of mechanical ventilation, the time when the duration of respiratory support or supplemental oxygen and the duration of hospitalization are all virtually identical between the two groups. So budesonide, intratracheal budesonide did not seem to have any influence on any of those important secondary outcomes. We, of course, looked at the standard range of neonatal morbidities, and again, there's nothing much going on there. I just point out treated PDA on the last row there. It has been a theme through many trials of steroids in extremely preterm babies that those babies exposed to steroids seem to have either less diagnosis or treatment of a duct, and you can see there's a 3% difference there that's almost significant, but not, and we're certainly keen to explore that in more secondary analyses. And we looked at growth because of the potential for steroid to get into the blood and cause issues, and that there's no differences in Z scores at 36 weeks post-menstrual age between the groups. The other thing we wanted to know is, did the budesonide itself cause any short-term harm? So we included these outcomes that we thought could result from steroid side effects. And again, scanning through the results there, you can see that there are no important differences in any of those. I'll just point out of interest that 2/3 of these very small babies had hyperglycemia greater than 10 or requiring or receiving insulin treatment in the first 2 weeks of life. Very high rate of hyperglycemia. So in conclusion, for the main trial of PLUS, in this international multi-center trial that enrolled a population of extremely small and immature babies, early intratracheal budesonide mixed with surfactant, compared with surfactant alone, did not result in an important increase in survival-free of BPD at 36 weeks, in contrast to the previous randomized control studies. We saw a small but insignificant increase of 2.7% in survival-free of BPD with budesonide, but no important differences in any subgroups and no difference in other respiratory outcomes or potential adverse effects. And of course, like any steroid trial, or in fact any trial of early interventions in extremely preterm babies, we need to know about longer-term outcomes. So we've moved on well and truly to assessing surviving babies at 2 years of age, in fact at 24 to 30 months corrected age. Here are a set of triplet girls all having their assessments at 2 years old that all survived and were in the PLUS trial. And we've got a battery of testing, both neurodevelopmental and respiratory, as well as some other things like quality of life and cost effectiveness going on. And we've already assessed 435 infants at 2 years, and including the deaths from the original trial, that means we've got 644 primary outcomes, but we've got a long way to go, aiming for over 90% outcomes at 2 years. Probably next year, I imagine we'll have those results. This is me in Toronto last week. This is Dr. Ambal from Birmingham, who's leading the NICHD Neonatal Research Network BIB trial, budesonide in babies, which is a very similar trial to PLUS in size and design. They're about 60% of the way through. We've already been in great discussions about pooling our data and looking at things together, so we'll certainly be doing that. The one major difference between PLUS and this trial is that in the BIB trial, they're using antenatal consent and aiming to give the intervention with the first dose of surfactant in all babies, which is absolutely the right way of thinking about it clinically. Of course, it will be interesting to see the trade-off in their trial of will they manage to enroll the smallest, sickest babies in that scenario. So we'll wait and see. And this is Sam Axford. I'm not sure if he's on the call, who's working at the Children's Hospital in Melbourne, and he's looking specifically with some of the other heart experts that are here today at the effect of budesonide on the duct in the PLUS Heart sub-study, and we're hoping to have some data from this in the coming months. just behind me in my office here is a whiteboard where I've been frantically writing down ideas as they come to me. And I guess one of the great things about a big cohort of babies like this is that we have the ability to look at a whole lot of other things that are of interest to us in neonatology about these babies, and certainly keen to look at some of these other outcomes and how they relate to longer term outcomes in other papers. So I'll leave you there with this amazing group of individuals that made this trial happen, and hope we've got lots of discussion coming up. Thank you.
Thanks, Brad. Beautiful story, disappointing results. And that's probably where this first question is related to. And I think you've talked about this before, but I would love to hear that again. How come your trial didn't work?
Yeah, so, well, it's got two ways of answering that. How come the other trials did work and how come our trial didn't work? So, I mean, I guess I'll start this by saying, you know, we've conducted a large, well-powered, multi-center trial. We were very diligent in its design and its undertaking, so we're confident in its results. We've enrolled a population of very small and sick babies, and that might have something to do with it. And what I mean there is that the risk of death or BPD in a 22-weeker is 100%. The risk of death or BPD in a 23-week is probably 100% or close to it. It might be that this dose of budesonide or doses of budesonide is just not going to have an effect on such a little sick baby where there's so much inflammation and so many things happen to it through the course of its stay. If you compare that to the previous 3 YEA trials that enrolled a more mature population, albeit babies that were receiving oxygen respiratory support, maybe that's got something to do with it. Maybe, if you like, the lower risk babies are more likely to benefit from this intervention. It's just enough to get in and do the job, and maybe they're at lower risk or lower than 100% risk of getting BPD. So just to summarize that, maybe nothing we do in these little babies is going to stop them getting BPD, and maybe BPD is the wrong diagnosis. However, you know, comparing our more mature cohort that was enrolled in PLUS, because we did have 26 weekers and 27 weekers, there was also no effect in that subgroup of babies, or very little effect. So there's something different between the trials that is making them get different results. Is it an ethnic thing? So, you know, do Southeast Asian babies have a different response to steroids? There's been other studies showing that they have different responses to different interventions. We'll certainly be keen to look at that with Sam and see whether there's anything going on either between centres or regions or ethnically that could be important. And otherwise, I'd be happy to hear from others about why they think that we've got different results than the previous trials. I mean, if you just think of it purely from a statistical perspective, small trials are more likely to get a result than big trials. I think we've done a fairly definitive trial showing that this is not the silver bullet for BPD.
Now, look, and I think that is reflected in the chat box as well. You know, it's an awesome trial giving us important information, what works, what not. Maybe a little bit, I haven't seen it, but is there a difference in grade 2 and 3 BPD? Because you started the story by saying BPD grade 1, you know, on the longer run actually didn't make much of a difference. So maybe we should only focus on, say, death and grade 2 and 3 BPD.
I'm just going quickly back through my slides here. Here's the Jensen severity, and we can look at it in different ways of doing it, but you can see there nothing going on in moderate to severe BPD either. From memory, the A trials showed more of a reduction in the mild BPD than the severe, and in the more mature babies. So I don't know, there's maybe something going on here in the populations and or the ethnicity where maybe babies that aren't super, super sick and super, super immature might have something to benefit from here. And maybe those that are, you know, as I say, we enrolled so many little babies, maybe this is just not enough for them. It's just not going to work.
Okay. Callum wants to know if you have spoken to people who actually adopted this in clinical practice. And you know, now you come with these trial results. Have they called you and said, now what am I supposed to do, Brett?
Yeah, it was interesting being in North America where many of those centres are. Now, I haven't spoken with the Taiwanese. I was hoping they were going to be in Toronto as well, but they weren't. So I'm not sure what's happening there. But my understanding is that, as you might be inclined to do, the studies that were conducted in your region that have shown a dramatic benefit, probably going to go ahead and do that and ignore maybe ignore the results of this trial. But in North America, for example, where some centres have moved to using this and have been doing for years, they're moving away from it now. Plus has been accompanied by some centres that have been doing this as a standard practice of going back and looking at their own data. And there was, in fact, another study presented at Toronto, a before and after study showing no effect, despite the intention despite the effect they thought they would see in the real world. So I think many of those North American centres will stop giving budesonide. As a counter argument, there's no harm from using budesonide in the short term, and it costs $1 in Australia. I'm not sure what it is around the other parts of the world. So I guess you could make a case that, at least as far as we know, you might keep going. But I think the combination of these results and some audits showing no effect means you should probably just stop it and wait and see at least what the 2-year outcomes are, which, you know, there's theoretically the chance that they'll show harm from steroid and theoretically the chance they'll show benefit. I mean, if there's benefit at 2 years, then despite these findings, then we might change our mind. Personally, I'm thinking, look at our 2-year outcomes, wait to see the results of the big American trial. Let's just say the Americans find a 5 or 6% difference and combine it with ours, and there's a 3 or 4% difference in something really important, then that changes everything. But I'd wait to see.
Yeah, no, I totally sort of see that sort of happening. And even, you know, 2% difference is still 2.7% difference, isn't it? And for some of these outcomes, that might be enough, particularly when the intervention is cheap, easily available, and easily to administer as well.
Yeah, we'll do a cost effectiveness study. I think I mentioned that, which will take a few years realistically to be finished, but we'll certainly look at that because it's just so cheap.
Yeah. Sam, you had your hand up. Sam, you had a question?
Yeah. Brett, excellent, talk. Always you are challenging with new ideas. My question is, about 22 years back, Henry Holiday did the OSEC trial, yearly steroid, systemic inhaled, 1 arm, late steroid, day 14, systemic as well as inhaled steroids, given for 15 days. And KK, we were part of that, study. And unfortunately, at that time, this concept of combining with surfactant as a vehicle was not there. And at the end, the message was steroid was harmful, when follow-up was done. In our PLUS trial, what is the concept? We are giving 1 to 3 doses of inhaled budesonide plus Curosurf. So how this can change the persistent inflammation that's going on in the new BPD?
Yeah, well, it didn't. So maybe that's the answer, Sam. But, the theory is that getting that medication into the lungs and having that potent anti-inflammatory might just tip babies over the edge into avoiding severe inflammation and the consequences of it. But clearly in this population, it didn't work. In regards to the dose, duration, frequency of how we should be giving this, I don't think we know the answer. I'll come back to later treatment in a minute. But for early treatment, in the first trial by Ye, babies received up to 6 doses of surfactant plus budesonide or surfactant alone in that trial, and showed a dramatic effect. So that's interesting, that concept of giving so many doses of surfactant being so foreign. But of course, the idea of the surfactant here is to use a safe vehicle to give a different drug rather than to give lots of doses of surfactant itself. When we designed this trial, we used the same dose as have shown dramatic effects in preclinical and clinical trials, and we've got a different result. Interestingly, during the course of the trial, we had very prominent people such as the Bellards in Roberta and Phil Bellard in America, who've done lots of amazing work around things like this, telling us that in their preclinical and clinical studies, they were seeing that this dose of budesonide was too high, that a much lower dose was resulting in evidence of adrenal suppression in preclinical and clinical models. And you can look up their papers, and their conclusion is clinical trials of budesonide should be considering using a much lower dose than what is being touted. So I'm glad we didn't use a much lower dose, because we just would have wished we'd done a higher dose. Is it too low still? Is it not being given enough? Does this need to be done 12-hourly for 2 weeks? I don't know. Of course, we don't know the answer to that, and it's something to think about. I know you didn't ask this question directly, but I suppose another question is, what about babies who have established BPD? Could we squirt some surfactant and budesonide into their lungs at 2 weeks or 3 weeks or 4 weeks or 2 months of age and have an effect? Should you let babies die without having given them some budesonide into their lungs? Should we be doing that routinely? We don't know the answers to these, but given that, you know, I guess my appetite for going down that path is a bit less now than it might have been 5 years ago, given the results that we found here. Yeah.
We did see a lot of adrenal suppression in the OSEC trial, and even with inhaled budesonide, because we gave high dose for 14 days. And unfortunately, this was not published. But the Hong Kong group, PCing and others, they published with flixotide. They saw adrenal suppression. And towards the end, it turns out to be harmful.
And yet there are many units around the world, including in our region, that are routinely giving inhaled steroids to babies with established or severe BPD, and many units who think that happens and that benefits babies. Anecdotally, they think that helps get babies off support. You know, we don't really know the answers to that either.
Thank you.
There's a couple more questions in the chat box. Barbara has a question about the rate of BPD in the infants who were not included into the trial.
Yeah, thanks, Barbara. We'll try and look at that. The short answer is I don't have the exact data here, but I can tell you it's going to be much lower than the babies that were enrolled in the trial. If you're interested in extremely preterm infants as a population, what I haven't done is looked at the rate of BPD, you know, from the 22 weekers that were enrolled versus the 22 weekers that weren't, and something that we probably should do. And check that we have enrolled a high risk group of babies, but I'm quite confident that that's the case. In fact, the sicker babies tended to be in the trial rather than out of the trial.
Yeah, which is sometimes the case, isn't it? The sickers are outside the trial, so I think that's well done. Irina asked if you're also going to include respiratory outcomes at 2 years of age.
Yeah, good question. And the answer is yes. We've got a questionnaire, a validated questionnaire called the Park questionnaire, which is mainly around wheezing and asthma and things like that for families. So we've got that. As you'll be aware, it's hard to do proper respiratory function testing until much later in life. So we're talking about whether to do that more in school age. The other thing we've got for many babies, certainly the Australian and New Zealand babies, and hopefully some others, is we've got what we call Medicare data. So we've got admissions to hospital, drug use, emergency department, intensive care visits through the first 2 years of life. So that's going to be really important because that's the things that parents care about. Now, having said that, and I'm glad we've got that, the fact that we showed nothing in severity of BPD, duration of respiratory support, duration of hospitalisation, I'm not holding out great hope that we're going to show major differences there, but you never know.
Arvind, do you want to make a comment about the Plus Echo and how the PDA might play a role in some of these results? He did tell me he had a very bad connection, so maybe he can't speak. But, you know, as a highlight, and Brett already mentioned it, we have analyzed quite a lot of echoes, I think. I'm not quite sure what the total number was.
I think it's around 150 babies that we're going to have included in the Plus Hearts trial.
Yeah, so we will see and have some more details about how the PDA played a role in some of these outcomes. Helen, what do you want to teach us?
It's just a bit of very ancient history, Kurt, but this was research I did with Phil Ballard when I was a neonatal fellow as part of a series of studies that we did that showed that glucocorticoids could have both stimulatory and inhibitory effects on surfactant production and on, Phil later on extended these studies to look at gene expression, like other types of gene expression in the lungs as well. So I think Brett's right that we don't know exactly what's going on at a cell biological level. when we give steroids direct to lung tissue. There's still some unknowns there.
1988, Helen, I was skateboarding around Melbourne in my Reebok pumps, I think, grade 5 of primary school.
No, I was very precocious, Brett. I was only in primary school. Just kidding.
No, you make a good point, and you know, in some respects, you can look at the results in PLUS and say, oh, well, you know, you didn't know what you were doing. Who knows what the dose should be? But the biological plausibility is really given to us by the preclinical and clinical studies that were already existing. I mean, we had 3 randomized trials showing that this was dramatically effective. So we did a similar thing, although albeit in a more important population of babies. So certainly disappointing, and I guess I'm looking forward to having a chat with the Taiwanese teams and seeing what their theories are. I've heard on the grapevine that they think that this might be an effective therapy for more mature babies rather than the tiniest babies as well. So we'll see.
Yeah, all right. All right, bang on the clock, 2 o'clock. Thank you all for attending. Brett, thank you so much for telling us this story and the results in a really clear way. You're just an exceptional storyteller. Thank you very much. Next week, we're going to continue on with some respiratory stories. We're going to get a story about RSV, where we are in the past, the present, and of course the future with our new sort of strategies which are coming around in the form of prevention. So I hope you'll see you next week again, and thanks all for attending.